Okay. Hello. Welcome to our Advanced Methods for Big Data Analytics in Women's Health. We're in session. It's a very different, obviously, as we've heard repeatedly. We work happy to organize this session. Myself, Graciela Gonzalez Hernandez from the University of Pennsylvania. And then we have Karen Berspoor, Maricel Can, Sue Golder, Lisa Levine, Mary Regina Boland, Natalia Villanueva Rosales, and Karen O'Connor. We're all happy to be here and welcome you into this session. We will be proceeding with the presentations for as slotted is 2 presentations, 10 minutes each, but we have time for questions, Q&A. We also have time for discussion after the presentations. But first, I would like to introduce some of the notions that we're going to be discussing and what motivated this session. So I've been working for some years, 11 or so or more, on digital epidemiology. Basically, this is epidemiology that uses data that was not generated with the primary purpose of doing epidemiology. It's the same goals as the typical epidemiology, but it requires access to large data sets and advanced analytics. And as the years have gone by, it has become clear that the methods that we use, I'm a computer scientist, my PhD is in computer science, the methods that we use are not adequate, like right off the shelf to deal with the large data sets. And not only just because the data is large, it's because of the way the data is set up and the way the data was collected also influences greatly how we make use of it. To complicate things more, there's many patterns in health that have been become evident through these years, particularly as it relates to women's health. So what we have is a reality where over 2/3 of women receive prescription drugs while pregnant, and the treatment and dosing strategies are based on data from healthy male volunteers and non-pregnant women. And this can have great impact both in the effectiveness of the drug and the way it is processed, the pharmacokinetics and pharmacodynamics of the drugs affect women, and not only in pregnancy. So these variations in physiology over the woman's growth from adolescence all the way to menopause. Hormones play a role as well. So it's not only during pregnancy. It has also been evident that many diseases, cardiovascular disease, asthma, eating disorders, lung cancer, autoimmune disorders, just to name a few, impact women differently than men, both in disease progression and outcomes. So all of these differences right now are not well known, are not well studied, are not even in the radar sometimes. So in comes sex as a biological variable. This is the way the NIH describes the requirement that researchers take this into account. It didn't come until 2016, so it's fairly recent. And the way that it's explained in the guidance, it says that over-reliance on male animals and cells may obscure understanding of key sex influences on health processes and outcomes. So I like the way somebody else expressed this without the inclusion of women all the way through from basic research to clinical research. We can't be sure we really have the right answers for 51% of the population. So it is not a trivial matter. It is not a small thing. It is really a very big thing. And just using as a point of reference this 2016 guidance, we are a little behind in these studies. So in this session, we're going to explore 3 full-length papers. One of them was presented as a poster. So we're going to see 2 presentations. They were competitively selected for inclusion. The first 2 is oral presentations, just happen to be, they're not related, the research groups are not related, they happen to be on one very important topic, is in intimate partner violence. So the first paper, in co-occurrence patterns of intimate partner violence, the authors present a method that learns patterns of survivors of intimate partner violence. In the second one, they attempt to do injury prediction. So they have an algorithm to predict which patients will experience injury as a result of intimate partner violence. The third paper was presented as a poster yesterday. You can still see the presentations. They are listed in the PSB guidance. I can find more information as to exactly how to do it, but I know the posters were there presented as mini videos, so you can always go check it out. So this paper was Not All C-sections are the same, investigating emergency versus elective C-section deliveries, is by Canelon and other authors, and they present a method that utilizes electronic health records data to break down C-sections and study the differences in the patterns for them. So this gives you just a quick overview of what is to come. And as I said, we're going to have some time for discussion towards the end. And welcome. And again, thank you for attending. I'm going to give it all over to Maricel. She's going to be presenting or introducing the 10-minute presentations that we have scheduled.
Hello to everybody. Well, great. Thank you for a great presentation, Graciela. Very cutting-edge topic, as you all noticed. I was wondering if we have the first speaker, Irene Chen, if you're there. Otherwise, we're going to go and start with the second speaker. We had two oral presentations today, one by Irene Chen for MIT, and the second by Gunnar Karakut from Case Western Reserve University, Cleveland, Ohio. And in the initial contact, we didn't see Lisa. So I'm giving, yeah, we don't see her. So why don't we just go ahead? We introduced the first presentation for the co-occurrence patterns of intimate partner violence by Gunnar Karakurt from Case Western Reserve University. And then we'll see if we get the other speaker next. Okay, so go ahead and start the presentation.
Good afternoon. My name is Gunnar Karakurt, and I'm at the Department of Psychiatry at Case Western Reserve University. Today, we are going to talk about co-occurrence patterns of intimate partner violence. Intimate partner violence is a prevalent public health problem. According to CDC data, each year, 1 in 4 women experience severe forms of violence. IPV is a relationship problem that can be seen in different forms. Physical violence can be defined as hurting or trying to hurt partner by hitting, kicking, or other types of physical force. Sexual violence can be defined as forcing partner to take part in sex act when the partner does not consent. And emotional abuse can be defined as any type of abuse that involves the continual emotional mistreatment of a person and harming a person's self-worth or emotional well-being. Microaggression can be considered a special form of emotional abuse and can be defined as subtle aggressive behaviors, including micro-insults, invalidation, and minimization of victims' experiences. Again, according to CDC data, victims of violence often become fearful about their safety, develop PTSD symptoms, need medical, legal, or advocacy services. Intimate partner violence affects victims' health both in terms of mental and physical health through acute and chronic conditions. When we look at EHR data, we see that cardiovascular, gynecological, gastrointestinal, mental health issues are more frequently observed among victims of violence. Many women develop PTSD, depression, and anxiety as a result of violence too. In this study, we are aiming to investigate different forms of IPV to understand which forms co-occur together with other forms of violence. We are also examining the relationship between these co-occurrence patterns and the intensity of violence. Answering these questions may provide insights in tailoring treatment to guide the needs of each relationship. In order to investigate co-occurrence patterns, we utilize data from the National Intimate Partner and Sexual Violence Survey. In this data set, there are 18,000 participants reporting different forms of violence. We filtered data based on violence reported in the last year. And after filtrations, we had 873 participants. To give you an idea about what questions were asked to the participants, physical violence questions included: how many times did your partner slap, kick, burn you on purpose? Psychological aggression questions included: acted very angry towards you, told you that you were a loser, failure, not good enough, insulted, humiliated, or made fun of you in front of others. Sexual violence items emphasize lack of consent and ask how many times your partner made you to show your sexual body parts to them, grab parts of your body, force you in various sexual acts. We first look at the frequencies of each item. We observed that psychological violence aggression is most frequently reported as compared to physical or sexual violence. On the other hand, sexual violence was reported less frequently. To see which items tend to exhibit similar patterns of reporting, we visualize the items in two-dimensional principal component space. The most frequently reported item, called you names, ugly, fat, crazy, stupid, is part of a psychological violence, but it's over here, but it stays apart from other items in this space. It is conceptually somewhat different from other items. So we decided to use this item as a separate form of violence, microaggression. We then look at the Venn diagram to assess the overlap between participants reporting each form of violence. The numbers show the number of participants who reported each form above average. Percentages show percentage in the entire population. We observed that psychological aggression and microaggression overlap more with other forms, while sexual violence overlap less. These are absolute numbers, so we looked at the significance of the overlap as well. Here we are looking at the overlap between each pair of forms of violence using odds ratio. If odds ratio is larger than 1, this indicates that these are more likely to co-occur. If odds ratio is less than 1, then they are less likely to co-occur together. We see that physical violence and psychological aggression are quite likely to co-occur together. The confidence interval of these odds ratio is well above 1. Similarly, psychological aggression and microaggression are more likely to co-occur. Interestingly, the odds ratio of sexual violence and physical violence, sexual violence and psychological aggression, sexual violence and microaggression is below 1. Next, we wanted to look at the co-occurrence of individual items. For this purpose, we constructed a co-occurrence networks of items. We can see that, for example, over here, we have a microaggression with strong, with strong interaction with psychological education and some interaction with physical violence. We see that sexual violence forms a separate kind of a separate component, but there are two physical violence items that interacts with sexual violence. One of them is burnt on purpose, and then the other one is pulling hair. So to see the relationship between co-occurrence and intensity, we develop a radial visualization technique. We use different colors to indicate different types of violence. We use the saturation to indicate the homogeneity of violence, and then brightness as a way of measuring intensity of the violence. When we map all these data points closer to the center are less severe, while when we are moving from the center, these are more severe cases. When we look at all the data map on this radial visualization, we see that physical violence and psychological aggression are more likely to co-occur. When they occur, the violence intensifies over here. Also, in order to understand the subtypes of violence, we used k-means clustering, and based on our analysis, we came up with a 5 clustering solution. When we map these into radial display and the principal component space, we can see that these are separate from each other. To annotate clusters, we looked at the distribution of each form of violence, as well as trauma and health symptoms in each cluster. The third subgroup, it's over here, is the one that shows health and trauma symptoms. This is a group that reports both physical and psychological violence. So when all of these forms of violence is happening at the same time, the health outcomes are much worse for victims of violence. And actually, this is consistent with past research that higher levels of exposure to psychological and physical violence simultaneously link to higher levels of mental health issues and lower recovery rates. Relatively, low overlap of sexual violence with other forms suggests a different dynamic for sexual violence. Findings of this study can be helpful in guiding targeted treatments. Standard treatments are providing anger management groups for perpetrators and mental health support groups for victims of violence. Inclusion of particularly emotional abuse treatments for the perpetrators, we can improve the treatment outcome. Also, the methodology developed in this study can be utilized in other psychological and behavioral health problems as well. It is critical to replicate these findings in different populations, including LGBTQ+ communities, as well as globally. As I complete my presentation, I would like to thank NIH and NLM for their funding, my department, and university hospitals. And thank you very much. We are looking forward to your questions. Thank you.
That was a great presentation. We have We have 5 minutes now for questions. I will be moderating that part, so please send your questions. Trying to see if I see any.
There's a question.
In this case, men are the minority. Do you have any specific insights into the differences between male and female, and what to do about it?
So, one of the differences that we see is women are experiencing more severe violence as compared to men. And the injuries and physical harm is much more severe for victims of violence for women. When we look at the literature, we see that emotional abuse is more common among men. And, there is this age difference as well. So, like there is an interaction of age. For example, for younger women, the physical violence is much more severe, but for older men, we see that emotional abuse can be more severe, depending on the situation. But, for intimate partner violence, usually the difference is, it's a very complex problem. And, when we see the situations, it can be, depending on what kind of type of violence is there, and also it changes the range and the severity of violence too. So, we have all kinds of, different range of violence where, we can see that there are throwing things and, insulting with verbally and things like that, to a more severe form of physical violence where there are traumatic brain injury or, even death can be happening. So, the range is really severe and different.
I have another question from Larry Hunter. The independence of sexual violence from psychological and physical evidence violence is surprising to me. Is that consonant with previous work? What explanations might be relevant to understanding that difference?
I think this is a great question. So, as I'm a clinician, I'm a couples and family therapist, and I work a lot with violent couples and, victims of violence. And, when we are working from, from clinicians' perspective, the general assumption was that when these kind of violent patterns are happening, all of them are happening at the same time. If, a person has been a victim of sexual violence, they are more likely to be victim of physical violence, or, that was the assumption that, we are running our clinic. But, from the data point, we don't see that. I think, it depends on the perpetrator. So when we think about the perpetrator's mindset, we can, think that a person who is trying to control and physically assault someone can be a different kind of person than who is trying to get a pleasure from another person without their consent. So when you think about the perpetrator's profile, I think, the difference is, it can be much more obvious.
I don't see any other questions. Do you have any?
May I add something in response to this question?
Sure.
So
you want to introduce yourself?
Yes, I am Mehmet Koyutürk, so I was
Sure.
part of the project as well, and I happen to co-inhabit with the PI of the project.
He's my husband.
Taking opportunity to also join. This was our first attempt to dig into this data. And we made every effort to, remove confounding factors by focusing on violence in the last year only and so on. But still, there is a lot in this data. It is a complex data set. So in our first run over the data, we tried to simplify it, make it as flat as possible. But still, although we tried to remove the confounders, actually those confounders, for example, the duration of the relationship could be one reason of the difference between the sexual violence versus other types of violence. I don't want to speculate much, but I think it makes sense to me that those confounders could be effective. So I think if we look, I think there is some in this data set, but also with other data sets, if we look more in depth to those types of potential confounders, potential variables, I think we can gain insights into what relationship factors are underlying this co-occurrence. And I think as we look for explanations, we can also find more explanations on the relationship dynamics that underlie each of these different types of violence.
Thank you for the explanation. We have another question, but unfortunately we just ran out of the 5 minutes for this. We're going to have a live discussion, a webinar right after this. So I just typed that question and I'm going to move it for the discussion later. So that way we don't run out of time here. Thank you. And we're going to move now. I don't think we're going to have Q&As from the next speaker because she's not present, but we're still going to play her presentation. Irene Chen from MIT. So we're ready now to play that video.
Hi everyone, my name is Irene Chen. I am a PhD student at MIT, and today I'll be presenting our work on early detection of intimate partner violence from radiology reports. Although it's only me presenting, this work would not at all be possible without my fantastic team of co-authors spanning 5 institutions, as evidenced by all of these different logos. Intimate partner violence is an urgent and widespread public health concern. Intimate partner violence, IPV for short, and I'll refer to that for the rest of the presentation, is a subset of domestic violence where the violence is perpetrated by an intimate partner. According to the United Nations, half of all women who are killed globally are killed by intimate partners or family. In the US, the Centers for Disease Control estimates that 1 in 3 women, 1 in 10 men will experience physical, sexual, or psychological violence and or stalking by an intimate partner during their lifetime. This is incredibly serious because intimate partner IPV victims have a greater risk of health concerns, including fractures, more visits to urgent care, more imaging studies than their corresponding controls in the general population. On the flip side, these days, machine learning has seen a tremendous increase in performance due to the increasing availability of data and advances in computation. Specifically in healthcare, with electronic health records becoming more prevalent, we see that algorithms can screen patients for different conditions with performance that exceeds human specialists. Can we perhaps do something about IPV victims? And so can we do early detection of IPV victims using machine learning? The biggest barrier to entry for early detection of IPV is in fact underreporting. The patient, sometimes the victim, feels shame or is maybe economically dependent on their abuser, or there's a lack of trust in the healthcare system. So despite the fact that clinicians see IPV victims more often through urgent care imaging studies, they may not know it. In particular, imaging studies are a fertile ground for detection and analysis. So we would like to look at this task of predicting if someone is an IPV victim, or specifically, is this a very severe form of IPV? Are there injuries due to IPV that we could detect early to make sure we target the most important, the highest risk patients? So for the first prediction task, we use patient self-reporting as the label for IPV victim or control. We match, so we collected data from a violence prevention program at Brigham and Women's Hospital, and we matched by age and sex to get patients as controls. We wanted to specifically look at radiology reports, so we only include patients who have at least one radiology study. For data, we did not use the images. In fact, we used the report that the radiologist writes about the image into the text. And the hope is that this will allow us to glean the most important bits and also leverage that human expertise of the radiologist looking at the image, understanding what's most important about the image. Our label in this prediction problem is then if the person in question is an IPV victim or in the control cohort, which is a label that we do know. For our second prediction task, we wanted to detect if there was a serious injury. So here we wanted to study injury patterns that a radiologist would be able to detect and see if an algorithm would be able to predict on that. So here we only focus on known IPV victims. Then we use radiology report text, again, not the images, radiology report. And the labels here, it's a little different. We used emergency radiologists, very diligent, very focused radiologists who went through all of the imaging studies and were able to label manually whether or not this patient from the radiologist report, whether or not you were able to tell if this patient had suffered an injury. Before running any prediction analysis, it's important to understand the patient population. So we analyzed what all these different cohorts look like, and a few things jumped out. One is that age-wise, we primarily have patients between 30 and 50. This is sort of the age distribution that we're working with. Second, because of our inclusion criteria and the way we're collecting different patients, we did not have any men in the IPV prediction problem. We do have some men in the injury prediction problem, but it's important to note that there's no men in the IPV prediction problem. That's because of the way the cohorts were collected. All right, so let's bring in the machine learning. How are we going to set up this model? So the first thing that we decided is that we wanted, because patients come in multiple times with multiple radiology reports, we didn't want to bias for patients who are coming in multiple times. We wanted to not take patient history into account and make our model the most robust for a single glance look at each patient. So we do not look at patient history, we treat each visit separately. In our trained valid splits, test splits though, so our different cross-validation splits, we split them by patient to avoid label leakage across the folds. Then we tested 5 different machine learning models, including a state-of-the-art contextual word embedding model known as Clinical BERT. So this is BERT trained on mimic 3 notes, which is using from Beth Israel Deaconess Medical Center. So training on some clinical notes, and then all the other models use bounded words instead, representation. Of our model results, we found that random forests performed the best. So note there is some overlapping confidence intervals, and these are computed across 5 trials, 5 different splits of data. But random forest seems to outperform the rest. But if we were interested in questions of interpretability, we might be useful to use another model, for example, logistic regression, which is what, in fact, we did. So here we're interested in what kinds of words would be most predictive, what kinds of patterns would we find. In logistic regression, the coefficient for each word in bag of words has a different weight. And so we found the highest value weight, the highest value positive weights. We sorted by that, and it turns out that these words align very closely with known radiologic findings for IPV. For example, fractures and soft tissue swelling, for example, hematoma, are consistent with known patterns of IPV. So this is incredibly encouraging that our model is picking up on the right trends. Next, we wanted to analyze performance for different subgroups of our data set. So we looked across age, gender, race, and marital status. We set sensitivity, since this is a true positive rate, to 95% across the entire population. we set that threshold, and then we computed the accuracy for each different subgroup. Here in the table, the bolded values indicate much lower performance than other comparable groups. This may be sometimes due to the size of the data set, though, and so we would need to investigate this further, certainly before deployment, to make sure that our algorithm is able to be performing well on all populations. So how would this be useful? How can we make sure this is actually going to be clinically meaningful and useful for IPV victims? One way to check this is to see how much earlier than program entry we can detect IPV. So as I alluded to earlier, it's important to consider sensitivity, the true positive rate, and specificity, the true negative rate. High sensitivity means we detect everyone who is an IPV victim. High specificity means we don't have false alarms, that we don't erode trust in the algorithm. Here we set specificity to 95%, and we find that we can detect IPV with this threshold a median of 3.08 years before the patient self-reports and enters a violence prevention program. Once identified, this is incredibly exciting, once identified, clinicians will have a possible number of steps, including referral to a social worker. Looking forward, it's important to think about how this model can be useful. So one, we need to consider which interventions to offer patients. According to the National Domestic Violence Hotline, on average, an abused woman will leave a relationship 7 times before she leaves for good. It's possible that detection is not enough then. We must understand what interventions will be the most helpful. Next, we want to consider how to make sure that we're not making doctors even more stressed out. Doctors are already incredibly busy. So with all predictive models in the healthcare setting, we must consider how to integrate it into the existing clinical workflow. Lastly, we want to consider how a model trained at Brigham and Women's Hospital in Boston might work for other hospitals in the country, and how it might be, how it might need to be adjusted. Additionally, populations can change over time. For example, during this global pandemic, research shows that the rate of IPV has gone up significantly and that victims delay seeking care until later stages of the abuse. So we must make sure that a model can accommodate shifts in the patient population. So in summary, we have shown that IPV, we can address a very urgent, serious, widespread public health concern with fairly accurate prediction models and achieve early detection, although future work is need to be done. For more details, check out our paper. Thank you.
Very impressive models. Unfortunately, the speaker, very impressive models. Unfortunately, the speaker cannot make it today. So we have a few extra minutes, and what we're going to do, you need to look in your chat for the next webinar link, and we'll see you. We'll get a few extra minutes now of a pause. We'll see you in the webinar, and we'll bring all the discussion topics among all of us. If any of these questions, if this one, this very good talk, probably elicit some discussion. If some of the expertise in the panel could actually address it, or at least discuss some of the topics, we'll do so during the discussion time. So there is a link that you should go next, and I think we have 6-7 minutes to do that. We'll see you then in a few minutes. Okay. Thank you for being there.
We're looking forward to discussion.